Hi everyone, welcome to today's webinar.
All right. Well, good afternoon or good morning to members of our audience here, and welcome to our webinar, which is our healthcare provider year in review and a look ahead into 2023. My name is Mark Ross, and I lead our healthcare provider practice at Baker Tilly, and I'll be introducing some of my colleagues here to you shortly. But before we kick things off, I do want to let everybody know that the slides we are going to use in today's webinar are not going to be content-rich slides. This webinar is going to be conducted a little bit differently. We're going to be doing it in the form of a panel discussion, whereby I'll be moderating the discussion. I've got the easy job here. I get to ask all of my colleagues questions, and then they're going to be responding to those questions. Again, all of which tie into what the healthcare provider environment looked like in 2022 from our perspective, and everything we've seen as we worked with our clients through this, what continues to be a very challenging time. And then we'll have some commentary throughout the next 75 to 90 minutes on what we can expect, what we're looking to see as we look ahead to 2023. What we've outlined here are just some industry themes from 2022, and these 6 things that you see here on the slide. This is not an all-inclusive list. Let me say that first. There are a number of other things we could have included on this particular slide, and my colleagues are going to be referring back to each one of these as we go through our Q&A. But again, some of the major themes: workforce. Workforce issues are pervasive across every type of healthcare provider, quite frankly, and they're not, across every industry sector. I mean, it's not only healthcare, right, that's experiencing workforce issues. So those workforce issues certainly having an impact on profitability or margins that healthcare providers are able to generate in today's environment. Volumes. We talk about volumes in the health system space, inpatient, outpatient volumes, the continued migration of inpatient volumes to outpatient settings. In the senior services space, when we think about volumes, we think about occupancy levels across all levels of care, for example, for a retirement community. In the behavioral health space, it's all about volumes, and certainly with specialty and ancillary providers, the top line, right, the volumes, generally speaking, drive the business, and there have been volume challenges, again, across every provider type that we certainly work with. Reimbursement issues or challenges, and we're going to be touching on some third-party payer expectations, reimbursement expectations as we look ahead to 2023. We're also going to be talking a bit about managed care contracting and value-based care, but reimbursement challenges and even what we'll call funding challenges in the behavioral health sector can continue to impact profitability of healthcare providers. Inflation, I don't think I need to say anything more than just that one word, inflation, and the inflationary environment certainly having an impact on healthcare providers, not only on their operations, right, their operating costs, but also providers that are looking to build new things, right, expand into new geographies. The construction environment, construction costs have risen dramatically. And then we get into the increase in the cost of capital, and really what we're referring to there is the interest rate environment, right? The escalating interest rate environment, and that's had an impact. And then, we have M&A, a lot of M&A. You can't read, Modern Healthcare, McKnight's. I mean, anything healthcare related, HFMA. You can't pick up any sort of publication or emails are coming across every day talking about new M&A transactions that are happening, again, across every single healthcare provider sector. But most of these issues that you see here, right, most of them, have resulted in healthcare providers, generally speaking. There are some that would not fall into this category, but healthcare providers, generally speaking, struggling a bit financially, right, incurring operating losses, maybe that have been heavier than losses they've incurred in the past, or experiencing operating losses maybe for the first time in their history. Financial sustainability, when we think about workforce, volumes, reimbursement, inflation, it all ties back to financial sustainability. And those 2 words are something healthcare providers, I believe, are thinking a lot about today. What changes do we need to make today operationally, strategically, to make sure that our organizations can remain financially sustainable moving forward. So again, a little bit on some industry themes, and my colleagues will be piling on as we move through our dialogue here. But I'm going to go to the first question that I have, and somebody had to draw the short straw, and that's Deb Bowes drew the short straw for the first question, which is, Deb, from a healthcare system perspective, what are the top challenges when we think about financial challenges, operational challenges, even strategic challenges, facing systems today? And as you think about the challenges that you've seen across the clients that you've worked with in 2022, are these challenges here to stay as we look ahead to 2023, or what's your outlook for 2023?
Well, I think my clients would all tell you they wish that these struggles weren't going to be there into 2023, but I think that they are. And the financial and operational challenges really seem to be tied together right now. And I think for the majority of our providers, it's dealing with the operating losses. I mean, you mentioned earlier, they're pretty significant right now. And you've got a time period when the investment markets are down. So piling on top of these significant operating losses, the huge investment losses that they're seeing. I mean, and the key driver with those operating losses, for the most part, what I'm seeing is the staffing levels, the workforce that you mentioned earlier. Not enough clinical people to see all the patients. Kind of depends on the market. I've seen some markets where the demand is there at the patient side, but they don't have enough clinical people to fill the slots to take care of the patients. And then other areas where the demand just isn't back there at pre-pandemic levels. But until the staffing issue gets resolved, none of the facilities are ever going to get back to their pre-pandemic volume levels. So it's just going to continue to get worse. And so they're filling those holes with contract labor, which we all know the contract labor costs are just through the roof for just about every provider out there. So then they add on top of that all the inflationary costs. The cost of supplies is up significantly too. And then, I think we'd all agree they probably need about a 20% bump in reimbursement from the payers to really cover all these increased costs that they're seeing. And those increases just aren't coming. I mean, as much as we'd all like to see it, I think it's probably not realistic to see those increases coming through. So I'm seeing a lot of clients very close on meeting their debt covenants, or they're failing their debt covenants. And for a lot of them, it's the first time that that's happened. So they're either in a stage of having to go get waivers and have those difficult conversations with the bank, or they're having to go out and hire consultants to do the consultant reports to tell them what they need to do to turn around the operations. But all of that is making them very focused on the right now. And we all know in healthcare, you're usually looking 3 to 5 years down the road. Not you're focused on today, but you also have to be focused on tomorrow. And I do have a concern that a lot of our clients aren't really able to focus on that strategic planning because these day-to-day operational issues are just taking their eye off the ball so much. And that's not going to be sustainable. So.
Mm-hmm. Mm-hmm. Good. Okay. Well, I should say it's not good, actually. I shouldn't have used the word
No,
good.
it's not good. I mean, in fact, I think as we get into 2023, I think we're going to start to see more and more providers really starting to think about how to right size their operations, and that, okay, if this is the staffing level that I've got, how can I best manage that? I've already got clients talking about, taking a look at their real estate portfolios and monetizing some of the offsite facilities and kind of getting back to a little bit more things under one roof or in a closer campus. So it's definitely interesting times in healthcare.
No doubt. No doubt. Jen, from a senior services perspective, what are your thoughts?
Yeah, so we've started using the term headwinds. It feels better than maybe the word challenges. But I would say a lot of what we're seeing with our aging service providers today is nothing new, right? This is stuff that we've been talking about for many years. It's workforce issues. What we're recognizing today is that it's centered around, much like Deb just alluded to, staff availability, and add to that wage pressures because of the competition. And in aging services, we're competing for nurses. We're competing with the health systems. So you have that natural tension, as far as wage pressures that occurs. All of that has been driving the number of residents that are able to be served. And so it is really staffing driving census in aging services, and that has the ripple effect on profitability. So when I think in addition to that, a lot of this is starting to feed the conversations around what I say is the business model in how we deliver services. And so it's causing us to look hard at what are the number of beds that we might have to keep open because of staffing. We don't have the staff to fill. And it also has caused some of our providers to consider constricting their services in order to limit the losses and the operating losses that they've been faced in the short run, because they may not be able to sustain that short run pressure. Add to that some of the ripple effect coming from the health system when you think about demand for the demand for nursing home services. We're seeing declines in referrals to nursing homes as there's a larger push for home-based services, which has another ripple effect to some of that profitability. I'd also say another challenge that we're facing is increased scrutiny from a regulatory perspective. Surveyors are really focused on infection control. We're seeing higher penalties. We're seeing a number of pressures there in order to make sure, unfortunately, aging services, and particularly the nursing homes, are still rebounding from a lot of bad press through the COVID pandemic. And so that manifests in many different ways. Mark, you mentioned inflation. We're seeing obviously inflation doesn't just come, it comes triple-fold when you think about your vendor sources and supplies that are needed. So a lot of things that continue to build. We know as aging service providers that the nursing situation is not going to be fixed in the next 2 years. We're watching the number of nurses that are, enrolling in programs and those that are graduating from programs. So we know that this is going to carry into 2023, and possibly we've predicted even further, pushing quite a few years, unless there's some meaningful impact in how we can attract and increase that workforce population. When you also contemplate the interest rate environment, just the added pressures, because we are still encountering aging properties and facilities. And so when you start to look not only at the delivery model, but also the buildings that we're trying to prepare for the future, and not only our future consumers, but also our workforce. I mean, our workforce wants the environment to be able to serve in. And so having to reinvest in today's environment is twice as hard. In addition to the operational challenges, it's the uncertainty in that interest rate environment and that increased cost of construction or renovation costs as we're continuing to reinvest back into our property. So I always feel a little bit of Debbie Downer, which is why I like to think about it more in terms of our opportunities to position ourselves for continued success. When I think about some of the things that we're encountering today and that we most likely will encounter in the next year.
Yeah, challenges always bring opportunities, Jen. I think that's your overall point. So Krista, from a behavioral health perspective, what can you offer?
Well, let me start with a positive, since we've been talking about some negatives, is that the demand for behavioral health services has increased greatly. And I don't believe it's because people need more services. It's because some of the stigma around getting services has gone away in the last few years. So that's a positive to providers. Some of the challenges that are coming through that is that staffing, as Deb and Jen just discussed. There's not enough people for the services. And I have clients who've actually closed programs, even though the demand is increasing, because they can't staff the need. And then when you do have staffing, you have to pay so much more than you did previously to compete with Walmart, compete with McDonald's, to get the individuals to come in and actually help those individuals. We've talked about for behavioral health for a while about parity, how we're not reimbursed at the same rate as you would for a primary care physician. And that's just intensified as we've gone in, as costs have increased through inflation, obviously the wages, and how do you pay your workers and to have that infrastructure that you need in order to serve our clients. We're also switching very much to an MCO model. We were an industry that were cost reimbursement previously, so that switch over also affects operations. How do we get the right technology in place? How do we make sure that we know what our costs are? How are we looking at the right metrics? And then we're also telehealth. The move to telehealth was something new for behavioral health through COVID. And how do we right size and really understand operations in that new model? And I still have clients, especially inpatient, that are impacted by COVID outbreaks. And so that might be something a little different for behavioral health than the other sectors when, you have inpatient services for rehab and then one of the patients tests positive. What do you do in those models? So there's a lot of things that are similar between, I think, all the sectors, but maybe a few other nuances with behavioral health. I don't think those go away. I think we're going to continue to look at that through 2023, but I think there's some positives along with that as well.
Good. And as as Deb, Jen, Krista taught, and I mentioned it at the beginning, workforce is really one of the primary themes across the board. And I wish we had that that magic formula to give everybody listening, here's the fix, do this, and the workforce issues will become a lot better tomorrow. But we don't have that. But what we are seeing is, obviously, it goes without saying, increasing compensation arrangements, evaluating benefit programs, really the onboarding process, the orientation process for new team members at your organizations. It's so critical to make sure that that's a seamless process. That really, right out of the gate, you need to create that engaging culture, right? That equitable, inclusive. You want to create that sense of belonging with your new team members. And I just think across our client base, the human resource area, right? The resource area at all of our clients, they're getting more creative than they ever have been in the past relative to, recruiting, retention programs, and things of that nature. So a lot to think about there. Joe, I'm going to pivot to you here. And we read a lot about private equity firms, Joe, investing in healthcare provider type entities, home health, hospice, physician, surgery center. You name it. A lot of private equity funding going into the healthcare provider space, but it's not because it's easy, right? Getting into the healthcare provider space isn't easy. So what are the challenges that, from your perspective, and Joe does a lot of work with private equity firms investing in healthcare entities, what challenges those firms face when they're investing? What are some of the things they need to be thinking about?
Sure. First, when we think about private equity investing in the provider market, I just want to state the obvious. We know that these private equity firms need to generate a high rate of return on their investment. And really, when you think about it, it's really over a short period of time. So all the things that Deb, Jen, and Krista have spoken about, those impact these provider entities that are being invested in as well. Higher costs, supply chain issues, the workforce challenges, and especially now the higher interest rates really all put a strain on earnings and really reduce leverage, which has become ever since COVID has become a real challenge in the private equity area while they're investing in these provider entities. And really what we've seen over, I would say many years now, is just there's been a lot of competition amongst PE firms when investing in these provider entities, which has really driven up the valuations of these healthcare acquisitions to extremely high multiples. And when you think about it, when they're investing with these high multiples, there's really a really small margin for error, especially when achieving earnings projections. And so that can be a real challenge. And we're seeing in the market now, ever since COVID, in 2021 and 2022, Many of these entities are working with lenders, renegotiating leverage ratios. Many of them have failed their covenants and are obtaining waivers and really looking at projections and reforecasting projections going forward due to all the challenges that we're talking about here today. Another challenge, and I think, Mark, you had alluded to this, and we'll speak more about this later in the presentation, is just the ever-changing regulatory environment and the payer models within healthcare. It could be a real challenge to predict growth, and predicting growth for private equity entities is extremely important factor when they invest in healthcare companies. They really model out growth, really invest for growth, looking to the future, and be able to accurately project growth into the future with all of these headwinds is a real challenge. And I just want to spend a minute on behavioral health. We're certainly seeing a lot of investment in behavioral health from private equity. There's certainly a lot of fragmentation in that area, so we're seeing a lot of investment. And what I'm seeing in the market, and really to add to what Krista had said, is due to staffing shortages and the amount of demand for behavioral health services, and not being able to meet that demand is really putting a strain on earnings and meeting projections.
Yep.
And Mark, just to close, Mark, we speak a lot about these challenges. I think Jen has spoken about opportunity. I do think there's significant amount of opportunity to improve healthcare delivery through innovation, and private capital can provide the fuel that's really needed for innovation, which could lead to reduced costs and improved outcomes.
Yeah, no, great closing, Joe. Sorry, I didn't mean to cut you off, because I was going to go to the next slide, which is sticking with you, Joe, and you've already made reference to some of them, but some of the trends. What are some of the trends you're seeing as we think about private equity investment, what we saw in 2022, and as we look ahead to 2023? So that would be on the next slide.
Sure.
Trends.
Sure. Yeah. So just speaking a little bit about deal flow, although the number of healthcare deals in 2022 has slowed when compared to 2021, private equity firms have continued to invest at a real high rate in healthcare companies. And that's expected to continue in 2023. Healthcare, when you think about it, it's a stable industry, considered a stable investment, as the demand for healthcare services will always be there. In addition, there's still just a significant amount of market fragmentation amongst these outpatient, smaller type ancillary providers. So there's a real opportunity for efficiency, for consolidation, consolidating the market in various subsectors. Also, Mark, many of these smaller outpatient ancillary providers are really not operating with much innovation or even efficiently. So there's many opportunities for investment to really capitalize on a solid return by making these organizations more efficient and innovating. So just thinking about 2023 and looking to 2023, the high deal activity in healthcare is expected to continue, as I mentioned, but I would expect really with the higher interest rates that buyers will be more selective when deciding where to allocate resources due to the impact on leverage and the cost of capital. Looking at subsectors, it's really impossible to predict the subsectors where the most amount of deal flow will happen in 2023. But with innovation being so critical in healthcare, I would look for many more health tech deals, as well as many more deals in the provider markets that are still very fragmented. For example, behavioral health, home care, veterinary care, and various other traditional provider specialties.
Okay. So we certainly expect, again, deal volume to be high,
Yeah.
Continued flow of significant funding into the healthcare provider space from these private equity firms, Joe. So one thing I neglected to mention at the beginning is as you're submitting questions to us for responses, we are actually going to hold on responding to them until the very end. So if you can actually, in case we get a lot of questions and we don't have time to respond to everything, if you can actually put your name attach your name to the question, and we will do our best to follow up with you. Again, if we don't have time today during the time we have here together to respond to your question of value-based care. It's something that my colleague David Gregory is very, very passionate about. David and I have been talking a lot over the years about value-based care and the evolution of value-based care, maybe the acceleration of value-based care arrangements or lack thereof, actually, in this post-COVID environment. So again, value care has been talked about a lot. We do see it as something that is going to, I believe, continue to evolve. But the pace with which it's going to continue to evolve, I think there's a bit of a question mark there. So David, my question for you is, relative to value-based care arrangements, are you bullish? Are you as bullish as you once were? Because years ago, David was pretty darn bullish. Or are you a little bearish at this stage of the game?
Yeah, the bloom has come off the rose, Mark. I would say that you are correct. I was bullish 4 or 5 years ago, and maybe even as recently as 2 years ago. I would say now that slightly more bearish on value-based care. And I know Krista said that behavioral health is just entering a form of value-based care, and here we are talking about the bloom coming off the rose on value-based care. So our system has some issues for sure, and we need to figure it out. But I there's more and more evidence that value-based care is not the final answer, and that we need to iterate. And Joe said it very well a few minutes ago. Innovation, right? I mean, care innovation is where it's at. I've been around long enough. I'm not gonna bore you on a decade by decade history, Mark, because I know we need to make up a few minutes possibly with my time here. But man, every decade or so, we have a push towards changing the way we deliver care, and hopefully that creates some cost savings opportunity, and it allows health systems to be financially healthier. And we're kind of 0 for 4 in my lifetime. I mean, in the 80s and 90s, we had pre-authorizations, and that didn't generate anything. And in the 2000s, we had let's all integrate and merge, and let's all get into big systems, and we'll figure it out. And that really didn't generate much. In the last decade or so, since Medicare introduced VBC in 2012, right? We've been trying for about a decade to get VBC right, and I don't think we have. So I think there's pockets. I mean, certainly if you've got a lot of resources as a health system, almost to the point of infinite resources, you can make value-based care work for you. But I also think that there's a lot of systems that are appropriately cautious about value-based care. So I am less bullish than I used to be. I still think it's a pathway forward, but it's not in and of itself, the answer, right? And I do think that care innovation, which we'll talk about a little bit more as we get through some of these questions, will be really important. As Jennifer said about, let's not use the word challenges anymore. Let's use headwinds. I think value-based care has not progressed for a couple of major reasons. The amount of investment required. As Deb said, operating losses are at the top of everybody's list. There's not a lot of investment opportunity, and everybody just invested in Epic and Cerner and Meditech, over the last decade or so, right? In fact, there's even a question as to whether those investments were really worth it. I think that the jury is still out on those IT investments, but man, those were huge investments. And value-based care requires similar investment if you're really going to be successful. Hospitals don't have that. They simply don't have that. And so that's a major headwind, especially with the gut punch we had with COVID. I mean, COVID was a gut punch, mostly to the provider system. I would submit to everybody that the payers and pharma and med tech, they're okay, financially. But the providers are limping, and as already well chronicled by everybody else that went in front of me. The other headwind that I think is creating some slowness around value-based care is the diversity. I mean, you've seen one value-based deal, you've seen one value-based deal. A hospital or health system could end up having 20 different deals with with 10 different payers, including the government and all the private payers. And, that makes the need for investment even larger. And the last thing I'll say is that the return on investment has not been seen yet. The entities that have, enrolled 500,000 lives in value-based care. We've got a couple clients that are right now reevaluating their value-based care strategy. They got up to 500,000 covered lives in value-based arrangements, including downside risk. And they're now saying, you know what? That may not be the end game. That may not be the answer. Let's look at other alternatives. And it's not just about the reimbursement side of the house. It's also about the care delivery side, which gets back to Joe's comment about we need to really leverage innovation, medical technology, and we'll talk about this a little bit if we get to our hospital at home discussion about just thinking about new ways to deliver care. I mean, that's got to be our mantra going forward, because value-based care in and of itself, is not necessarily the full answer. But I don't want to be a David Downer. I think somebody else said they were a Debbie Downer or a Jenny Downer or whatever it was. But I do. So there are pathways to success under it. But I'm trying to give reasons for why it hasn't happened wholesale. And there's a survey that HFMA did recently that asked a bunch of CFOs and C-suite health executives if quality would improve materially if the system were largely value-based care, and over 40% said no. Now, if you've got a system not believing that value-based care will improve quality, and you got upwards of 40% plus not thinking it's going to move the needle on quality, then we got an issue, right? We got a perception issue that we need to work through for sure. So anyway, I applaud everybody else's comments so far. Tried to build on a few of those, and welcome challenges from the audience in terms of what their view of value-based care is, and we'll see if we have any questions later.
Good deal. So just for the record, David, at the beginning of his comments, said he was going to try and help us make up some time. He did not do that. I just want to he did not do that. So with that said, I'm going to go back to the first polling question just to share the results. The biggest hurdle over the next 12 to 18 months, not surprisingly, 60% of you said workforce. Workforce was going to be the biggest issue for your organization. 20% said inflation. 10% talked about volumes. So 90% of you were in those three categories. So just pivoting quickly out of value-based care and just into general third-party payer reimbursement for a second. We talk about Medicare, Medicaid primarily is what I'm referring to here. Jen, what's the outlook from a Medicare, Medicaid reimbursement perspective? And very difficult on the Medicaid front because we have obviously 50 states across the country, right? Different programs. But what's the outlook for nursing homes? And as a result of that outlook, how should nursing homes be thinking about budgets and things of that nature?
Yeah. Well, no easy answer there when you look at what the recent rulings were. We know Medicare Part A, when you really look at the entire components, all the different components, it actually was a net decrease to the rates that the Medicare Part A services for skilled nursing homes under PDPM. And that's when you consider some of the PDPM parity adjustments and the sequestration that comes into play. When you think about also the Medicare for home health services was also just a nominal increase. So really not very positive when you think about, basically, for all intents and purposes, a flat system when we're encountering all these pressures from wages and all the other inflation and everything we've already talked about. So that, and in addition to that, only talking about reimbursement, but wrapped into that is the added pressure of having to increase your quality measures, reporting, and outcome, and all of that really does impact your reimbursement. So while we don't talk about it as it relates to the payment, it really is a driver to the payment. As you mentioned, Mark, at the state level with the Medicaid systems, The good news is we're seeing some money coming from the state budgets across. We're looking at quite a few states right now who have allocated funds. It has ranged. They've had different mechanisms in which that funding has been applied. Whether it's been directed towards direct care costs for our nurses, or whether it's through other operating mechanisms. We are seeing some funding now. What we don't know, as can be with any governmental reimbursement, we don't know if that will continue. We have hopes that will continue, and is not just a one-time funding mechanism. The most recent example here, just citing Pennsylvania, actually approved a 17.5% increase to the rate, which is about $35 a day. Now that's our first increase since 2014. So when I think about it, it sounds, it is great. We're grateful and celebrate the win. But the reality of it is we haven't had a rate increase since 2014, and when we're watching all of the costs and pressures that are building going forward, I believe we're still playing catch up, and I'm not sure it's really positioning us to solve some of the fundamental costs and some of the fundamental issues that we're encountering in that business model. And that none of those funding sources really address, going back to my earlier comment on capital needs, none of those really address the capital needs and the fact that, I hate to say I've been in the business long enough that I'm now seeing the rebuilding of buildings. So none of those funds are actually available to help with the rebuild of buildings that might not be at the level of service that we need them for continued operation, as we're reaching 25, 30 plus years life on these buildings. So I hate to say, that outlook is clearly a driver, I think, to the overall sustainability of that nursing home business. That doesn't mean that nursing homes are not going to continue and they're not going to thrive. It's just that there has to be some creative ways to rethink how that either that delivery model adapts or changes so we can make sure that we can be financially sustainable.
Mm-hmm. Good. So Deb, on the hospital side, third-party reimbursement, what do we expect here as we look ahead to 2023?
So on the Medicare front, there was actually a nice little surprise in the final ruling that came out, and those are for the inpatient rates that just went into effect October 1st. It actually was an increase of a little over 4%, and in the tentative ruling where they had come out last summer, they were talking about a 3% increase. It was almost a 1% more. Although there's a lot of discussion about out there that really should have been closer to more of an 8% increase to get folks closer to the increased costs. When you look at, I think it was last year's cost report data and the increase in costs that they had, but CMS is using older data to determine, what these increases are. So I don't know if that means when CMS data catches up to where the hospitals are that they'll see even bigger increases. I mean, we are still dealing with CMS here, so probably not. But at least we'll take it for now. There are going to be decreases, though, in the Medicare dependent hospital payments. I think that was down about $600 million in total. And the future of those programs still a little bit up in the air. I believe they did get extended here until mid-December. So I think they're expecting some legislation to go through here in the next couple of weeks to extend those programs once again, because that's, pretty vital programs for a lot of the rural hospitals out there. And then on the inpatient side, on DISH and uncompensated care, those payments are going down about $300 million in total. But the original projection was that it was going to be a decrease of $800 million. So, win-win that it wasn't decreased as much as what the initial thoughts were going to be. And then on the outpatient side, it gets a little bit interesting. So they're saying it's an increase of 3.8%. And this goes into effect January 1. But the 2% payment sequester is going to be in effect again. They had tabled that the first quarter of 2022, and then It was only at 1% starting in April last year, and then July kicked up to 2%. So that 2% is going to be in effect again this year. And then you've got this whole issue with 340B drug payments. So at the end of September, there was a court decision that came out that basically upheld a previous decision from earlier in the summer that said that CMS was underpaying for the 340B drugs. And it's going to increase the reimbursement on those 340B drugs almost 30%. I think it's about 28.5%. But they need to pay for that somehow. So there's an overall decrease in non-drug reimbursement of 3% to offset the increase in those 340B programs. So how you're going to fare on the outpatient side really is dependent on whether or not you've got 340B money coming in and how significant that is for you. And then another point on the 340B, so on September 28th, when the court decision came out and said, okay, CMS needs to immediately start to reimburse the hospitals at the higher rate on the 340B drugs. So anything that goes through after September 28th, you'll get the higher reimbursement for. But for claims that you would have submitted during 2022 up till September 28th, where you got reimbursement for 340B, you're going to have to resubmit those claims to get that higher reimbursement. So it's not a situation where they made it as easy as, CMS running the calculation, send you a letter, say, review this, get back to us in a month if you don't agree with it, and we'll cut you a check. So they are going to make you work for those dollars, but I think for a lot of our provider clients, that's probably pretty significant dollars at stake there. So just a word of caution, make sure that you have good controls around that as you're resubmitting those claims and able to track that and keep track of those payments to make sure that you're getting all the dollars that you should.
Yeah, and Deb, just to add to that, I have seen a couple of my clients start to receive funds for the 340B for those earlier periods. Although you do have to work for it, they are starting to see money come in.
Good. Deb, as you were talking, the only thing I'm thinking about as you continue to talk is really the complexity, right? The complexity around Medicare reimbursement for hospitals. It's incredibly complicated. So many things hospitals need to pay attention to. You mentioned DISH, uncompensated care, wage index, paying attention to that, right? Evaluating your wage index, Medicare bad debt. There are just so many moving parts there that you've got to make sure you don't take your eye off that ball, because if you take your eye off the ball, you're going to leave money on the table, and it's money on the table that you're actually entitled to, right, for providing services. So just make sure most health systems have people dedicated to the reimbursement function, but the reimbursement function continues to evolve and get more complicated as time goes by. So pivoting now to behavioral health, Krista, on our next slide. We know that funding, so Medicare reimbursement isn't necessarily, certainly might be a little slice of the pie in behavioral health, but not a big piece. Certainly Medicaid funding and just funding in general, right, has always been an issue for behavioral health providers. And you mentioned, Krista, the increase in demand, right, which is the great news for behavioral health providers. But will the funding be there for these providers to sustain their operations and to provide the services that are needed in the communities in which they operate? So 2022 saw an unprecedented federal awards made to the behavioral health sector. So, what's your overall thought 2022 as we look ahead to 2023 on funding for behavioral health services?
So behavioral health gets a little complex, and I mentioned parity in my initial comments. And really what that is that if someone's in crisis and they have an event and they need behavioral health services, are they really being reimbursed at the same rate as if they broke their leg or they needed to have surgery? And so because of the squishiness around, a mental health crisis, it's harder to get reimbursed at a fair rate from the insurers. So many providers supplement that either with federal or state funding or private pay, which is easier to do for drug and rehab, but harder to do in other sectors. Or they're trying to find federal awards. So parity continues to have that drum beaten. I don't think we're going to solve the problem in 23, but with the demand in services, I do believe we'll see some relief in that area. And Mark, you mentioned that we've seen all kinds of federal fundings come in the second half of 2022. So maybe just to highlight a couple of those programs. So the Certified Community Behavioral Health Clinic, or the CCBHC, we've had that test for a while that's expanding at the federal level, and we have several states that are creating their own programs. The basic of that is like an FQHC for mental health. So they focus on crisis intervention, but then also care coordination. So when a patient walks in the door, we're also making sure that their primary needs are handled. We're making sure that they're getting to all the right appointments. We're making sure that, if they have some primary needs, that we're getting them to the right physician and we're pulling them through the process. And then the organization is paid at a fair rate for those services. So the CCBHC, as long as the funding is still there, and at this point it is going to improve behavioral health. We're also seeing that housing is a great need in behavioral health. If someone's in crisis, they can't get better if they don't have a stable place to stay. So HUD is actually looking for feedback on the expansion of the 811 program. That's for basically mental health services under the RAD program, so Rental Assistance Demonstration Program. There's also millions of dollars that HUD is holding in rental assistance for 811 that has not been released. So providers are also asking HUD to come through and say, let's release that funding and let's get more people into housing. And then finally, some of the funding that was released at the second half of the year is really going to be focused on mental health for the youth. By the time people actually get into the system and they get served, many times it's too late. So that funding is going to help us put providers into the schools. So almost $1 billion is going to go into that program, where we're going to have organizations have clinics within the schools. We're going to have providers within the schools. So I think those programs, along with the help in parity, should help not-for-profits meet the services for behavioral health. But I think there will still be challenges in 23.
Okay. And when we talk about, we use the word funding, right, for behavioral health, and Ken and Deb talked a little bit about reimbursement on the acute care, post-acute care side of the world. But I will say, just again, and our audience, our listeners know this, that funding, right, is also available in this COVID environment, right, that we still live in. A lot of provider relief funds, FEMA funding, other state and local government grants that can help a provider offset maybe some increased expenses relative to COVID. There continue to be some announcements, little buckets of money, here and there that maybe providers can avail themselves to. So make sure you're keeping an eye on those funding streams. But just as important, getting access to the funding, you better make sure you understand the compliance requirements related to the funding, right? Any reporting, any accountability you have, back to the funding source. Because generally speaking, the government's just not going to give money away without some form of accountability. So keeping an eye on that would be something we strongly recommend. And we've certainly worked with a number of our clients on those sorts of funding mechanisms. So on the next slide, I'm actually going to skip the next slide and move into managed care contracting. So David, back to you. Managed care contracts, managed care contracting, again, in light of all these challenges we've already addressed, right? I would imagine a number of healthcare systems are taking a harder look today at the rates they're being paid by payers, non-Medicare, non-Medicaid payers than they ever have before. And so what are you seeing in this area, relative to providers looking at their managed care contracts? And then have you seen any changes in relationships, right? That providers and payers have to have good relationships. They do need to work together, generally speaking, right? I mean, it should be all about the patients and outcomes, improving outcomes. So what are you seeing in managed care contracting in general and on the relationship side of things?
Yeah, no, it's important. I mean, it's that relationship between the health system and the managed care organization is one of the most important levers to pull when you're looking for more revenue. And I think, Deb, you said it in your opening comments that a 20% increase from the managed care companies would certainly help, close the gap on some of the operating losses that are out there across the industry. And we're not seeing 20% increases coming from the payers right now. I think, and there's a couple reasons for that. I would say that, that first of all, health systems can't just go to the payer negotiating table and say, have you heard the news? There's a big inflation problem out there. Can you give us more money? That's not going to, hearing the news is not going to fly. You really need to be systematic and analytical about it, and you can have some success. And what I mean by that is cost per case, right? And not cost by department, not cost by any other metric, right? But cost per case. When a managed care company is paying a health system, they're paying for a medical surgical day, right? They're paying for a maternity stay. They're paying for a colonoscopy, right? They're paying for discrete services, and they want to understand your cost at that level. And I know that's a challenge for a lot of health systems, but if you're going to make inroads and get more than a quote unquote cost of living increase, you need to do some analytics in order to really get at those numbers. And then you have a chance to have some success. We actually had more success pre-pandemic than we have in this quote unquote kind of quasi post-pandemic phase that we're in right now. I think payers are really holding the line, because if they set a precedent with one or two systems in a geography, everybody's going to hear about it informally. And the payers are very concerned about kind of a network-wide increase that could be very difficult for them to sustain. Although, frankly, I would just add that they probably could sustain it, because I think their financial health is pretty solid coming out of COVID. However, that's their concern, right? And it's difficult to kind of break through there. But I think, and also remember that the perspective of the managed care companies is they are typically paying 110, 120, 150, 200, or even more than 200% of Medicare, to most healthcare systems, right? So they're sitting there saying, man, I'm paying 220%, to your facility right now, and you're telling me that doesn't cover your costs? What does that mean for your Medicare population, right? And so you have to kind of get in their shoes and say, okay, well, that 220%, that sounds like a big number. But when you consider that Medicare is only covering 75% of my costs, and I think Deb might have mentioned that, but on average, in the 90s, hospitals would get 100% of their costs from Medicare, and now it's slowly migrated down to about 75% of their costs, right? So there's the loss that has to be picked up by the commercial payers, right? And they are largely doing that, but not sufficiently, for a lot of systems. But when you talk about asking for an increase from 200% of Medicare to 220% of Medicare, you better have a darn good reason and some data, to justify that, right? Because it's hard for the payers to kind of, fully kind of understand why such an increase is necessary. So unfortunately, we're not seeing the payers giving any handouts. They are good stewards of employers' money, right? And they always say, I'm managing my customer, which is the employer. I'm managing their money, and we're going to, have that give and take. The relationships have not really improved all that much, Mark. They haven't gotten worse, but I will say that, after a little bit of a honeymoon period when they paid for COVID testing free and things like that, it looked like they had a good side to them. The bloom has come off that rose. We just had a podcast with one of our clients earlier this week, Mark, where one of a prominent provider kind of indicated the bloom has come off that rose a little bit from a relationship standpoint. But it's doable. But obviously, as most of these topics have come across, you really got to be prepared, and it's a challenge for sure.
No doubt, and not to make light of it, David, because it is certainly a challenge. But I did like your opening line, and it does. Have you heard the news? That's just I don't know you want to start that way, but it sounded funny to me anyway. On just the integration, Krista, of primary care, behavioral health care, and any comments on that integration, which again has been occurring, but how are we going to see that evolve moving forward?
So this is really seen at one of the key ways to address the mental health crisis is the integration. And the pros is that it's going to improve patient and physician experience. Some of the challenges are the cultural differences between the behavioral and non-behavioral clinicians, the barriers to the flow of information, and then billing challenges, obviously, if you're integrated. So there's really three ways that we're seeing that right now. Primary care providers screen for needs. They refer to the behavioral health colleagues. We have behavioral care managers embedded with the primary care practice. So same facility, they monitor the patient's progress. And then the final way we see this is they're both providers are at the same facility and they coordinate under one management structure. So I would say in the majority, it's the first. I would hope we'd pull to the third, but again, it's going to take some time for integration because of those challenges that I mentioned previously.
Sure. Okay, so now moving on to our next topic, and that's the investment in technology. So technology investment, and I could have had that on the industry theme slide. As I said, that slide at the beginning was not an all-inclusive slide, but technology, healthcare providers across the entire healthcare continuum continue to make significant investments in technology, whether it be ERP, EMR, technology related to the provision of patient care, telehealth, remote patient monitoring. I mean, you just a lot of investment, tons of investment in technology. Deb, thoughts on that? What you're seeing with our clients in the healthcare system space?
Yeah, we've been seeing some pretty significant investments in technology, and that's been going on for quite a few years now. I remember back when I was a young staff, hospital capital budgets it was equipment and bricks and sticks. That was what you spent your capital money on. And now when I look at my clients' capital budgets, it's all technology. The IT department gets the bulk of the funding. We've seen a lot of money spent on EMR investments, I'd say, in recent years. Certainly some telemedicine investments and investments in scheduling systems, things like that during the pandemic. But the EMRs have been there for a while now. And I think for a lot of our client base, the jury's still out a bit on whether they're seeing a return on that investment. Because remember, these are pretty big dollars of investments up front for the initial system. And then there's ongoing operating costs that you're incurring with probably a larger IT staff, higher software costs, maintenance costs each year. And then typically, we're seeing a lot of consulting costs ongoing because you've always got some sort of reporting feature that you want to upgrade or, working the kinks out of the system. So those just become part of the ongoing costs after the fact. Now, the upside to all of this is that the providers have a ton of data at their fingertips. And the downside of this is that you also have a ton of data at your fingertips. What I see is, having the data is one thing, but having data analysts on your staff that can go through and scrub the data, they can sort it, they can, start to identify the trends in it and really make meaningful use out of that data so that you can use that in operations. That's the key. I just had a hospital CFO say to me a couple of weeks ago, Deb, having data is not my issue. Being able to use it is my issue. And I hear that a lot. So, one of the things that I would just say is if you're going to make those investments, try to make the best out of those major investments in the EMR. Have a plan in place from day one as to how you're going to get from implementing to turning on all the bells and whistles that those systems have. Because if you're not going to take advantage of all that your technology has to offer, you're probably cutting yourself short and you're not going to see that full return on that investment. Like one of the things that I see a lot of times is systems will wait quite a few years before they turn on, let's say, the module where it maybe writes the receivables down to net, or at least can tell you what your expected reimbursement is against your actual. Because, let's face it, there's a lot of bugs to be worked out in doing that. But the whole goal of having that type of technology built into your system is so that you're able to monitor those payments coming in and make sure that you're not losing out on money that you're entitled to, that you should get as part of your reimbursement. So I would say making sure that you're staying on top of that and getting those bells and whistles turned on. And the other item that I typically see with a lot of the investments in technology is a lot of now, and I'm not an IT person, so I'm probably not going to use the right terminology, but like kind of a system to kind of pull together all the data. You've got all these different systems doing all these different things for you. And sometimes it's just nice to have something that sits on top of all of that and creates a dashboard or kind of ingest this information so that management can use it. We're starting to see more and more organizations kind of get to that stage where that's how they're making meaningful use out of some of the EMR and other investments that they have. But only word of caution for providers is, at some point on a regular basis, probably take an inventory of all the software that you're paying for and make sure that you're using it all. Because a lot of times, when we look at that, you'll find that maybe you purchased an ad hoc piece of software to do this or do that, and it seemed like a really good tool at the time, but maybe there's been some turnover. Maybe you went through a system upgrade and now the two systems aren't talking. Just make sure that if you're paying for it, you're using it and you're using it to its full capacity.
Yeah. So Deb, in summary, what I heard is, regardless of the technology platform we're talking about, optimizing the functionality that you've purchased. I mean, all too often we see that it could be a healthcare system, it could be a senior services provider, or behavior. It doesn't matter. Across the healthcare continuum, there are technology platforms they're utilizing that all of the functionality has not been turned on, right? And so you're not getting as much return on your investment as you should. So focusing on the functionality, and then the data. Great point on that. Data can be overwhelming, right? And the CFO that you spoke to the other day, you and I talked about, I mean, they have an overwhelming amount of data at their fingertips, but how do they utilize the data to help improve their business, right? How do they utilize it, from a patient outcome perspective, from a financial perspective? So that is the challenge, right? That is just as much of a challenge as it is, utilizing or deciding what technology you're going to purchase. So Joe, any other comments on the technology side of the world?
Sure. Just what I'm seeing where most of the technology dollars going for these ancillary specialty providers, especially private equity owned. And Mark, you had mentioned the importance of collecting every dollar that's due to these organizations. So we're seeing a significant amount of investment in revenue cycle technology. Really what happens is these organizations, when they acquire a platform company and there's various add-on acquisitions, you could have several different billing systems or revenue technology that really needs to be implemented. And what they're looking for is best in class. They're looking to automate, looking to remove denials, and really just spending a significant amount of resources to get that piece of it right and correct in best in class going forward, because that's really important. Other area is telehealth. Real big move to telehealth amongst these providers. Really good tools to use to get reimbursement and off-site, and using those tools, especially in physical therapy arena. But really, a lot of the resources in those two technology areas we're seeing.
Okay, great. So I think we've got on the next slide, we've got a hospital at home topic here. And David, in 2 minutes or less, can you just talk briefly, hospital at home, we continue to hear about it, we continue to read about it, reduce cost, improve patient outcomes, improve patient engagement. It just seems like there's a lot of buzz around hospital at home. So briefly, what are your thoughts on it? Is it just a fad that might go away, 18, 24, 36 months down the road, or is this here to stay?
I hope it's not a fad. I would say less than 10% of hospitals have an active hospital at home program. So those of you listening to this presentation likely don't have a hospital at home program, but we highly recommend that you at least research it and figure out what the implications are, because it's important for a couple reasons. Just real quickly, workforce challenges are a problem, right? And if you can get a significant part of your inpatient population being served in their master bedroom instead of in your hospital, you actually take pressure off of staffing, right? And that's through the use of smart technology. We just talked about technology. This is a different level of technology, right? We have smart beds, we have smart pills, we have smart monitors, we have smart pumps and the like. And you can literally bring the hospital home and lessen pressure on staff. Mark, you already indicated the patient engagement early on is very positive. So I'm hoping it's not a fad. I think everybody should at least research it and assess it. And if you're concerned about what you're going to do with empty beds, then do a demand analysis to figure out whether or not you can backfill empty beds or whether you can close beds. As Deb said earlier, right sizing is on the table, for health systems going forward, and hospital home can do that. My last statistic, Mayo Clinic, 20% of their patients in 2023 are going to experience inpatient care at home. And the projection is by 2025, which, believe it or not, is only 2 years and change away, 40% of Mayo Clinic patients will get inpatient care in their master bedroom, as opposed to in a hospital. All right. And when you get to those levels, that materially changes what you do with the bricks and mortar, that are out there. Right. So it's a bit of a game changer. And should be kind of viewed as a potential game changer and not just some annoying, fad that's going to go away on its own. So that's my 2 cents on that, Mark.
So systems should be paying attention to it, David.
Yes.
Bottom line, right?
Yep.
And thinking about it, reading about it, maybe researching it a bit, potentially implementing a program themselves. So going back to one of the polls that we executed relative to managed care contracts, about 50% of the responses where the question was applicable relative to, are you going to be renegotiating your contracts? About 50% of you said yes. About 15% said no. And the rest of you said you weren't sure. About 35% you weren't sure whether you were going to renegotiate them. And that could be because maybe you're not in that particular area of your system. But if, I would think that most healthcare providers today, healthcare systems, the people in charge of managed care contracting, are on top of that, you would think. But if you're not sure, you should actually check with them when you return this afternoon. So the next slide is an M&A topic, and just I mentioned at the onset, you can't pick up anything healthcare related, the newspaper, a publication, anything where your M&A is not addressed, and it's across every sector. Right, healthcare systems. It's been happening for years and years and years with systems coming together, and now we have the whole, the physician integration into systems has been happening for a number of years. On the senior services side of the house, it's been happening. It's happening a lot over the years, but now it's at a much more accelerated pace, and certainly it's happening in the behavioral health space as well. So Deb, just starting with you on the healthcare system side of it. I mean, anything beyond what I said that it's happening a lot?
Yeah, it's still pretty active, and I'm seeing all sizes of deals. It's it seems like a lot of the providers out there trying, I think, to get to that $1 billion or larger size system. So I'm seeing those big systems do a lot of tuck-in hospitals to grow and grow and grow their market share. And now I'm even seeing good sized systems coming together and forming even bigger systems. So I think that's probably a trend that we're going to continue to see. And I part of me wonders if some of that, you get to a certain size and then they can maybe become a player in having their own insurance product, which kind of helps with the keeping all those insurance premiums in the same system, keeping in the family, so to speak.
Jen?
Yeah, so I think there's a theory out there that senior services tends to lag behind the health system activity by about 10 years, I think I've heard. I've never tested that, but we're definitely seeing a lot of activity as it relates to senior services. And I would say, we work with probably half not-for-profits and half for-profits. Clearly on the not-for-profit side, we're seeing some divestitures and sales to for-profit operators. So a slightly different approach in order to capitalize, I think, on some of those assets. And then we're also seeing affiliations come with among our not-for-profits as they're looking either to merge or affiliate with a larger system, or in some cases, try and find either like-sized organizations or smaller organizations that they can align with. I think one of the biggest things I'd want anyone to walk away with there is, and a topic that I've been spending a lot of time with boards on, is this concept of readiness as it relates to your either acquisition, merger, or affiliation, whatever word you want to use. This concept of readiness to make sure that as an organization, you've thought through internally and externally how your organization is prepared either for that opportunity that will be presented to you so you can move quickly, or how you can evaluate the opportunity regardless of the situation.
Got it. Krista, in the behavioral health space, I know Joe mentioned significant private equity money going into behavioral health, right, from an acquisition standpoint, but any other sorts of transactions or things happening in that sector?
So 2021 for behavioral health was a record year. So, we're going to go down from 21. I don't think we can beat 21 this year. In fact, some things I've looked at, we're down about 20% for mergers and acquisitions in behavioral health from 21, but autism is up 15%. So we're seeing a lot of activity in autism. So we are seeing not-for-profits that are affiliating with each other. We're seeing not-for-profits that a smaller one is merging with a larger one, but we're also seeing private equity come in and through some creative structures actually acquiring not-for-profits. So much like what Jen was saying, we're seeing a lot of activity in that. And it's really been driven by keeping up with technology needs, where maybe you have a very strong founder that's ready to retire and his or her successor isn't there yet. And really that move in the billing from cost-based to, MCO-based and the challenges with that and making margins and some organizations can't keep up. So although you don't hear about it in the news as much, there's a lot of activity right now in behavioral health.
Sure. And we talk with our clients all the time, everybody that's participating, and there's all of my colleagues talk to our clients all the time about things they're thinking about strategically, as it relates specifically to M&A. And I had a discussion last week with a client, and I know this is a bit exaggerated, but what I told them was, 5% of the overall transaction, identifying the right partner, right, is say 5% of it. Although people would argue it takes a heck of a long time to find the right partner for your organization. But the piece that we often see overlooked or underestimated maybe is the integration side of it, right? And that's what the work begins after you identify. If you're two not-for-profits coming together, right, the integration is what people need to be paying more attention to, because scale does matter, but scale only matters if you can actually leverage the scale, right, for the betterment of the combined organization. So I just put that out there, that do not underestimate, focus on integration, make sure you've got a team in place to make sure things are integrated well once you pull the trigger on a transaction. Question I have, or I guess where I'll be seeking comments from my colleagues, and this is kind of a call for questions here, the last call for any questions that people might want to submit. Please get them into the chat. And if we don't have time, as I said earlier, we will respond to your questions. We will reach out to you and respond. But top initiatives, strategies, everything we've talked about. Again, there have been challenges or headwinds, as Jen likes to say. I do believe that headwinds or challenges do create opportunities. And even though it's been very difficult, it's been an incredibly chaotic environment, right, for the last 30 to 36 months for healthcare providers. And it's very difficult to be strategic when your operations are in chaos, right? Things appear to be in disarray because you've got to focus on today, not 5 years from now, although we can never really lose sight of future strategy, because if we lose sight of future strategy, that will potentially impair our ability to perpetuate our organization. So when we think about top initiatives and strategies for healthcare providers, I'm going to go right around the horn here with my